vitals. They are CNS depressants, meaning they bind to the opioid receptors in the brain, which sedates the body. So again, memory trick, opioids, we have low and slow vitals. So low heart rate, low respirations, low BP, and a slow brain, which makes them very deadly. And again, they're not NSAIDs, so there's no antipyretic properties, so it's not going to reduce a fever, and there's no anti-inflammatory properties. So guys, it's not good for gout or rheumatoid arthritis directly. Second is opioids have the O's. So guys, morphine sulfate has an O, hydromorphone, codeine, oxycontin, and oxycodone. Now, the weird one here is fentanyl, which we'll cover in another segment. But really, all of them kind of sound like phone. So guys, remember to consult your doctor if you see low and slow vital signs. Now, tip number 3 is the killer side effects. When do we stop and give the antidote Narcan? Well guys, low respiratory rate, key term here is respiratory depression. And the key number, we hold dose for respiratory rate below 12. Now we're always going to teach deep breathing exercises to prevent the atelectasis and pneumonia. But, key word here, we never hold the drug if the patient is not practicing their deep breathing exercises. So we still give the med. Now for low BP, aka hypotension or orthostatic hypotension, we teach patients to go slow, so slow position changes to prevent fall risk. Now key term, if the client becomes dizzy or lightheaded, guys, immediately assist the patient to a sitting position. Do not get up unassisted, so teach the patient to use the call light when getting out of bed. Now lastly, the low brain for the CNS sedation. Key term here is easily falls asleep when talking and unarousable. Guys, we hold any additional narcotics. So monitor the respiratory status, and guys, sedation comes before respiratory depression. So be sure to watch out for this. Now you may give additional narcotics when the patient's LOC or level of consciousness improves. So when they're easily aroused or only slightly drowsy. Now if things get too low and slow and our patient starts to overdose, we can always give the antidote naloxone, brand name Narcan. It's an opioid antagonist, meaning it's a reversal agent for opioid overdose, as well as heroin overdose. Now the memory trick is we think of the X in naloxone, puts an X on the O's in the opioids. Guys, the bad news is that it's gone quickly, so we usually have to give multiple doses. So think naloxone is gone quickly. So the key point here to write down is 1 to 2 hour half-life. So we always have to reassess every 60 minutes. And we're monitoring for the persistent low and slow. So guys, the key terms here to write down. A respiratory rate below 12. Unarousable, falling asleep while talking to you. That was a really big one. As well as prepare for the second dose of Narcan. And notify the HCP if we have any of these key terms present. And guys, don't worry about calling a rapid response. We always assess the patient and prepare the Narcan, since this is an expected response. Now lastly guys, the priority nursing care is AIMS. So remember, first is A for assess the ABCs. This is priority during a respiratory sedation. I is for intervention of oxygen. M is for make the HCP aware. And S is for a second dose of naloxone. And guys, again, there's no need to call for a rapid response unless the airway and breathing are critically low. So below 12 respirations or below 90% O2 sat. Now, as far as IV administration of opioids like morphine and hydromorphone, guys, we administer over 2 to 3 minutes IV push. Big key term, not over 5 to 10 seconds. A fast push usually means a fast death. And we reassess after 15 to 30 minutes, not after an hour. Those are usually for PO opioids. Now, the greatest risk for death is for overdose and respiratory depression. And our patients with advanced age, 70 years or older, or underlying pulmonary disease like COPD or asthma, and even post-surgery 24 hours. Usually these are stressed on the question banks as the highest risk for death. So big test tip here, if you're given an option between two patients both with respiratory disease, for the most at risk for respiratory depression related to opioids, guys, always choose the oldest patient first or the most recent surgery. Now for short-term side effects that are normal, no need to report to the HCP. A burning during IV push. Well guys, that's perfectly fine. We don't have to hold the medication for this. We just dilute it and give it a little slower next time. How about pruritus, aka itching? Well, that's also common. No need to report, we just treat with antihistamine like Benadryl. And for nausea, vomiting when first starting taking the med. Key point here, write this down. Teach that the tolerance will develop and nausea will improve. So give antiemetics initially like ondansetron, brand name Zofran, and for PO opioids we take with food, not on an empty stomach, which may increase the risk for nausea. Now for long-term side effects, we get a low and slow GI leading to constipation. So key term here is PRN stool softeners and teach preventative measures like fluid, fiber, and moving like ambulation, basically walking. Now constipation gets worse over long-term administration, and it doesn't get better like the nausea. So many students wanted to hold morphine for a patient with a no bowel movement for 2 days. Guys, we continue to give this. And a little side note for oxycodone. Guys, just think oxycodone is like an old ox with a slower onset, typically used for extended release. So typically for severe chronic pain, example cancer pain, not like immediate release opioids which acts faster. There's a slower onset and extended release, usually over 12 hours. So we give it twice a day. And yes guys, we administer it together with other pain meds. So keywords to write down. We give it as scheduled around the clock. Big one right here, even if not reporting pain. And we commonly give it together with other pain meds. Now for PCA pumps, aka patient-controlled analgesia pump. The indication is it's usually used after surgery for long-term recovery. Now how it works is a certain amount of medication is set into the pump, and each time the button is pressed, it delivers that medication. So key points here. Guys, client only can push the button. No one but the client will push the button. Not the family, not the nurse, not the doctor. So guys, nursing care here. When do you notify the HCP for an increased dose? Well, only if the patient attempts are twice the dose of the med given. So if the patient still reports pain, well, the first action for you guys to do is a thorough pain assessment. So be careful. Tests will always ask for the best nursing response or the priority action. In the Nclex world, the priority is always assessment before intervention, because Nclex wants you to follow the nursing process. So guys, remember the acronym AIR. A for assessment, before I, intervention, and then R for reassessment.